Dr. Schmidt, it's good to see you again. An amazing result. People are still buzzing over your iliac case, so now the expectations are extra high. We have an amazing panel here to join you for your case. We have Dr. Christian Bianchi, Dr. Marianne Brodman, Dr. Eric Ducasse, Dr. Yan Gofik, Dr. Karthik Guja, Dr. Nick Moa, Dr. Peter Schneider, and Dr. Srini Tumala to watch your live case. So good to connect with you again, Dr. Schmidt.
Yeah, thank you. Thank you. So, yeah, after that, it was a little bit tough case, the first one. This, however, is therefore very peculiar and maybe not as we planned. Let's see. A case for discussion. Can you see the slides?
Yes, we can.
Okay, very good. Next, please. So this is next. Okay, yeah, you can see 78 years male patient, severe claudication, left thigh, gluteal, walking capacity 100 meters. SFA got treated several times. Yeah, you can see there were some restenosis also there, but actually the calf is okay now. Coronary artery disease, also cabbage. You can see the risk factors. And next is an angiography which we have received during a treatment beforehand. And yeah, so this is the situation. It's not as in the program, an iliofemoral case, but it's iliac and common femoral or a bifurcation, femoral bifurcation case, because here the hypogastric on the left side is occluded and the profunda. In fact, however, only one branch of the profunda. Muss mal jemand fragen. Okay. Yeah, sorry. So I think this fits to his complaints. And we thought maybe to open up here the profunda, which is very calcified. And we also thought to open up the hypogastric. It's not shown here, but in the previous angios, we could see a nice posterior gluteal artery. So we thought that could be a good goal. Yeah.
Very cool kind of case, very different than what we normally do. But maybe I can just go to the panel real quickly. If in terms of profunda or internal iliac artery revascularization, I know at the last last session we did talk about some hypogastric artery revascularization. Are you guys doing profunda internal iliac artery revascularization for cases like this?
Yes, we're doing that because a lot of these patients are not, accepted by our vascular surgeons because hostal groins, too many comorbidities, so especially if the patients have severe symptoms, we're doing it with all the caution of not doing any harm, but we are doing it.
I think your point is well taken. Dr. Schmidt was saying that the calf claudication has gone away, but given that both the profunda and the hypo is out, the patient's still experiencing pretty significant buttock claudication in this scenario. Certainly not a common case, it's when we're treating PVD for these patients. Okay, Dr. Schmidt, we'll go back to you.
Yes. Yeah, thank you. Yeah, absolutely. A very uncommon case. Thank you, Marianne, for your comments. So can we switch to the angio? Can you see angio? Please, angio, no slides anymore. Hello?
Yeah, we can see it.
Okay, good. Yeah, okay, very good, sorry. So once again, here, hypogastric occlusion, but and you can see here from one of the profunda branches, actually also not too small, some collaterals going upwards, filling here hypogastric, but seeing this, in fact, it's really quite long total occlusion of the hypogastric artery, very calcified. The previous angios, we thought it was shorter. That would be difficult. Yeah. We can also, however, not see really superior gluteal artery. Now this is left oblique. You can see one branch of the profunda, and here once again left oblique. So actually on our right side there should be some artery which would be worthwhile to connect, but maybe not here so much, sorry. So therefore, we thought first to do an angio from the right side, through the right hypogastric. We thought maybe we see some better fitting on the left side. Of course, this is left oblique, doesn't tell us anything, but you can also see that there is a stenosis on the hypogastric right. So this artery should be preserved, but there was no collateralization from the right iliac hypogastric to the left. So it's really, there's not a lot of blood. So again, I think this really fits to his complaints. We took the pigtail catheter a little bit higher. We thought maybe over lumbar arteries, iliolumbar connection, there could be a filling of the superior gluteal artery. Unfortunately not. We are a little bit something here. But not the typical, once again, left oblique to see really the gluteal artery, but it's not there. A little bit. I mean, sometimes if you get through and you open, then you suddenly see a big artery, but here I doubt this a little bit. Yeah, so therefore our plan maybe has to change. First, of course, we try now to open up the profunda branch. Thigh complaints. So therefore, this looks like a little channel, but I think it's not. It's a collateral maybe, but maybe it's also a channel. Yeah, and it's calcified, short. Okay, first this, and maybe thereafter we see more of the hypogastric. Yeah, sorry, changed a little bit the strategy here.
So are you thinking that that coming off the common femoral artery is a little channel or a collateral that's going into that branch?
I think it's a little collateral, but we'll see. Yeah. I have a catheter now in front. This is a, so I have a 7 French crossover. I have a mammaria shape, 6 French guiding, short. And in that I have a mammaria 5 French catheter to take really the curve. I cut the tip off a little bit to make it grab nicely here into the artery, into the wall. I'm gonna give you a little roadmap and see. But I don't think there's. I think there is no channel. So therefore But of course, I mean, here it's always really very difficult to know whether this is really in the right direction or whether we are poking here against the wall. I can try a little bit here now with this CTO wire.
Which wire is that?
And this went through. Okay.
Well, you made that look easy.
Yeah, okay, not so difficult, yeah. In fact,
which wire was that used, Dr. Schmidt?
We Win 200T 12-gram tapered wire. In fact, we were planning also, if this fails, to puncture retrograde the profunda, which is challenging. But then let me show you. We tried already to reach it somehow here to check out whether this could be possible. But in that case, so typically we go left oblique, we take a long needle, 9 centimeter, to reach down to the profunda. So that's actually not so difficult. But of course, you have to change C-arm positions several times. And in that right oblique view, we see that this branch, which we want to hit with a needle, is posterior. So it's very deep in the thigh, and therefore I think we didn't really try too much, just probe a little bit. Very difficult. So I'm happy I'm through here now from antegrade. Yeah.
Wow. Yeah. So I think for the audience, even though we saw this kind of relatively easier wire crossing, I think the key point is that Dr. Schmidt was taking a bunch of images
Das
to
ist
make
aber
sure
der
that he was
Katheter
able
noch
to
drin,
get the
ne?
correct
Ja,
image
das nehme ich
of
raus.
that profunda
Richtig.
branch. And he ended
Können
up
Sie
at
den
an oblique,
rausziehen?
even if you see on the screen right now, an oblique that is completely opposite of what we would typically think about for the profunda origin as well. This lesion looks challenging. It looks like it's right up to the origin, almost a flush occlusion that's going into the common femoral. Okay, if I can ask the panel, maybe Srini, I can start with you. When you have a flush occlusion that's going into the common femoral like that, your treatment strategies, whether you're thinking about to make sure that you don't have any kind of stent that goes into the common femoral artery, perhaps.
Yeah, I mean, I think the first thing is what you said, Dan, is that if you noticed, you know, the symptoms alone were kind of interesting, right?
Oh,
I mean, how often do you see this kind of set of symptoms in somebody with just a single isolated hypogastric and even the profunda being out? But I think the key thing was the diagnostic angiography ahead of time. Stenosis of the contralateral hypogastric, the inferior mesenteric artery was not normal, diffusely small in size, diseased. So now it starts making more sense with the buttock claudication, the thigh claudication, because at first I was thinking, well, this doesn't really make sense. Now it makes more sense. Whether you do this endo or operative, I think you have some options here. I think if it's a good surgical candidate, you could operatively clean this out and fix it quite easily, I'm sure, you know, right? I think if you're going to tackle this endo, the key is not bringing your stent too far into the common femoral artery. But, you know, you can bring it at maybe a millimeter, and I think you would still be okay in terms of future interventions and not burning any bridges in the future as well.
For sure. Dr. Dukaze?
You mentioned the stenting of the ostium of the profunda, but there's also an alternative, ENREG, high ENREG. This is Eric Dukas speaking. You didn't mention this is to use the debulking directly, and debulking plus angioplasty to avoid any stent placements. That also makes sense.
I mean, I think in this case, I think, you know, IVL might make sense here along with DCB, and then you could hopefully avoid stenting altogether.
Yeah,
Would be
I
the
think from a
ideal situation.
surgical perspective, a profundoplasty, an open profundoplasty where we do an endart and putting a patch on, is a very durable and one of our favorite kind of options to do in vascular surgery.
And by the way, but we have a battle with Jan. I think the most important key point of the open surgery, you also improve by the way of enlarging the flow also into the CFA. That makes sense. So you enlarge the CFA, plus you're enlarging the ostium of the profunda. This is the global flow that is really improved.
Absolutely. Well, Dr. Schmidt, we were having a conversation about some potential treatment options of this pretty complex profunda lesion that seems to be going all the way to the origin. What are you thinking? What's your treatment strategy for here?
Yeah, we were also discussing, and actually we are also not yet decided what to use, in fact. So we wanted to wait for your discussion. So we thought, of course, also atherectomy, directional atherectomy for me to calcified. Otherwise, I like it very much in bifurcations. Jet stream, yeah, it's a relatively straight and stiff head. Maybe this curve is not appropriate for this, I don't know. Stealth atherectomy could be, I think, a good option. And we were thinking of either stealth or lithoplasty. What do you think?
So are you thinking atherectomy followed by balloon angioplasty, avoid stenting if you can?
Yes, vielleicht auch stealth.
Panel?
Ja, machen wir das.
Any other thoughts about it?
Ja, machen wir ganz schnell. Müssen wir mal. Das geht.
Ja,
I
könnt ihr
would
mal
avoid stenting.
das reinbringen?
Yeah. Nick, go ahead.
Was für eine Krone? CSI.
I was saying, yeah, I would
Stealth, und
think
zwar
of
halt
some adjunctive
Classic.
therapy such as IVL
Classic.
consideration,
Groß,
even if
1,5.
orbital. If they really want to do atherectomy, you could consider orbital given the small channel, but I would avoid stenting if at all possible here.
Yeah, I think I understand the idea that while IVL is good, first for sure, if you're angioplasty close to a bifurcation or close to an origin, you always worry about a little bit of plaque shift moving away while you're doing the angioplasty. So I understand the idea of doing the atherectomy here.
How many would put a safety wire into the SFA? Is that something you would
So
do
it's an
routinely?
interesting thought, right? Because when we're doing an SFA intervention that's very close to the origin, we often do put a safety wire into the profunda. Would the panel do the reverse, where since we're treating the profunda, put a safety wire in the SFA? Dr. Brogdon?
I would do a safety wire in the SFA because I always want to be safe. so that's I always fear that I lose, the access to
So,
the
Hammer?
SFA. In this case, vice versa, if I do the SFA, then
Klasse.
it was a safety wire in the profunda.
Certainly has some downsides of needing a slightly bigger sheath and access, but certainly I understand that as well. I think Dr. Schneider, you had a comment that you wanted to make.
Yeah, I was just going to say, I don't think we have the right stents for this issue. We don't have a T-shaped or bifurcation-shaped stent. We have Supera, but you don't know exactly how long it's going to be. It's going to be no good for the origin of the profunda. And I think stent avoidance is good here because it just would make it simpler if the patient later needed a femoral endarterectomy. Not impossible, but it's simpler. And then lastly, I'll just say, just putting in a plug for the profunda, we zoomed right past it, but this guy's already had SFA interventions. He already has common femoral disease. This is the type of guy that if he gets an SFA occlusion, he's going to have rest pain. He's going to have CLTI with his profunda occluded. So it's a good thing that he's getting that reopened at this point.
For sure, completely agree. It's the lifeline of the leg, as we often talk about when the SFA goes down. Dr. Goffin.
Just a comment about atherectomy for this indication. The best evidence for atherectomy is the level of DRG in the office vein lab. We know that's the highest, but level of is the main evidence. But in terms of scientific evidence, we have nothing.
Sounds like he's laying the groundwork for the debate that's about to come up, which I love kind of hearing. So Dr. Schmidt, I think we have a very interesting debate that we're going to have between Dr. Gofic and Dr. Ducasse. So maybe we can go to that and we'll come back to you and catch up with you.
Actually, he's going to run the CSI.
Oh, never mind. Sorry. He's on the verge of running the CSI. So maybe we'll come back to you and watch this live
Soll ich
before we
es
go.
reinfahren oder wollen Sie es eher?
Nee, anders.
Was macht denn jetzt?
Achso, Sie fahren es immer rein.
Ja, ich finde es irgendwie entspannter.
Wer macht was?
So Dr. Schmidt, can you just tell us the wire, what you're about to run?
Certainly, I mean, no filter. Usually we don't take filters, and especially profunda doesn't really make sense. A lot of side branches. It's an 014 wire. We choose here now. We have to switch to the Viper wire. Viper?
Ja, haben wir den
We
Draht?
haven't switched to the Viper wire yet.
wir
Which we
brauchen
need,
den Draht,
and
ne?
then we take a classic
Diesen Viper Wire.
2-0, yeah, a big one, but classic because it has to go through the curve, not a solid, straight, rather stiff crown. Yeah. Okay, so we still have to work and build up here a little bit, and then we can show you how it goes later on.
Sounds good. So we'll go on to our debate. Dr. Schmidt, thank you so much. We'll come back to you. Hi,
Yeah.
Dr. Schmidt.
Can you? Hi. Yeah, well, no, we have not finished. This case is different than any others, I must admit. We choose here a relatively big crown, as you can see here. The 2-0 classic because, as I said, not too stiff. But the tip went nicely in, but then the crown, not really. And then we thought, well, to celebrate the day, we'll take another smaller one, the micro crown. For this kind of lesions, actually, we always take micro crown. If a balloon doesn't go through the lesion, if we cannot open up the balloon, we take a micro crown through, and that worked actually quite nice until the catheter got somehow stuck on the wire, and everything went out. Yeah. And so the wire went out, and now we're actually struggling to get it back in. If we inject like this, we see that there's some kind of discontinuation of the proximal part of the artery to the distal. Don't know why, but if we inject through the iliacs, it's actually still there, no damage. But now we are really struggling to get the wire back in, and that's currently where we are. So I think you still have a lot of
Yeah.
time
Andre,
for
there might
next
be-
presentation before we can show you something.
Andre, there
Now-
might be a small plane which might have been formed because of the micro, and that might be giving you that direction of the wire.
Yeah,
Probably a
yeah,
knuckle
correct.
to push it in.
I mean, it looks like we're going to have a little bit more adventure. Dr. Schmidt, I think at the start of the presentation, you were saying maybe we were even considering sticking retrograde into the profunda and going backwards. Maybe there was a little bit of premonition, but excited to see kind of what you come up with here. So we'll come back to you, Dr. Schmidt. We'll be watching live on the screen
Yeah,
as well.
thank you.
So maybe we can go to you, Dr. Schmidt, just get an idea. I know that you're still working here, but give us an update on what you are working
yeah.
on, what your strategy is.
Wow. Yeah. Yes. So in fact, from antegrade actually was not possible. Somehow dissected. I don't know. Yeah, you could wait maybe until maybe something had changed by itself. But then we thought, well, let's try to puncture this deep femoral branch. And we took now a little bit another needle. Can you show the needle here? We took the 18 gauge needle, or gauge, I don't know. And through that, we took a long needle, the 15 centimeter, can you pull it through? And with that, actually, it was, now it was suddenly not so difficult to reach that deep branch. You can see here that we were now aligning the needle, hopefully with the roadmap. Can you see here the angio?
Yeah. Yes, we can.
And in the other angulation, you can see already, sorry, this is now roadmap still image, that the needle hit here the deep femoral artery. And then, we took the wire in. But the wire is not going the right place now. And now we took the needle out and take a support catheter in and try to drill from retrograde. Yeah.
Wow.
So not yet
Got it.
finished, but
We're going to come
hopefully
back
on the
to you
right way.
again. We'll go to our last talk and we'll come back to you. Dr. Schmidt, thank you for giving us that update. And once again, thank you for bringing these challenging cases to do live for
Yeah,
us.
thank
We
you.
can all learn from. But let's go back to Dr. Schmidt. Dr. Schmidt, I know you've been working. We see some angios that have been coming on. Let's go here for some updates.
Yeah, we are some steps further. So as you can see here, we were struggling a little bit now from retrograde to take the wire in. Of course, there was not lots of support, but eventually here an 014 wire, PT2 went through. Whether it's through another channel or not is not really clear here. But we were actually happy now that the wire's through, but the wire turned downwards. And thereafter, we thought we'd take a low-profile balloon in, as you can see here, over the wire, 220, very low-profile coronary balloon, would not pass here through the calcium. Yeah, so at the end, of course, next step was here just to snare the wire then coming from above with a snare, taking it down, and the wire here then into that snare. That was actually very easy here to catch it. I think here we catched it. And then, of course, we pulled the wire out of the right groin. And thereafter, of course, with a pull-through wire, now we could take any balloon in here. So first a low-profile balloon. This is now 420, 520. Yeah, it is very calcified. This is 520 now. Still, we have to work on that. So, this is not following actually the plan we had, but at least we are through and we have this artery open, and we will continue now with a high-pressure balloon.
That looks
and then
incredibly
finish
better
the
than where
case.
we started from. And it was great to see kind of the advancements of problem shooting that you've been having.